Welcome to the Deep Dive. We're here to cut through the noise and give you those key insights, really custom tailored for you. Today, we're taking a close look at a health condition that affects millions but is still often misunderstood. Polycystic Ovary Syndrome, you've probably heard it called PCOS. So our goal today, we're sifting through, a lot of information to pull out what really matters for your understanding. We'll look at what PCOS actually is, how doctors figure it out, its impact, which is broader than you might think, and importantly, how it's managed. Get ready for, hopefully, some real aha moments.
Exactly. And PCOS often gets labeled just as a reproductive issue, but our sources really show it's systemic. It affects the whole body, metabolism, mental health, everything. And how it shows up is so varied, which is why, as we'll discuss, getting that diagnosis can be, well, a pretty complex journey for a lot of women.
And that's precisely why getting a good grasp on this quickly is so valuable, isn't it? Because people can spend years feeling uncertain. We want to give you that shortcut to being informed, really shine a light on this common condition. So let's start right at the beginning. Let's tackle that core question. What is this condition? It affects so many people, maybe 5 to 10% of women of reproductive age globally, which is huge, but it can be hard to pin down. What do our sources say it is, fundamentally?
It really is a major health issue. And the key thing to get about PCOS is that it's what doctors call heterogeneous. That basically just means that it looks different in different people. There isn't one single presentation. Now, there are three main features doctors look for. First, irregular periods or maybe no periods at all. They call it oligo-ovulation or anovulation. Basically, you're not ovulating regularly or maybe not at all. Second is signs of excess androgens, sometimes called male hormones, though women have them too. High levels can cause things like hirsutism, that's thicker, darker hair growth in places like the face, chest, abdomen. Yeah. Or it might be acne or even male pattern hair loss. And the third thing is polycystic ovaries seen on an ultrasound. Lots of small follicles, basically.
Okay, but here's something that really jumped out at me from our sources, a potential aha moment. Despite the name Polycystic Ovary Syndrome, you don't actually need the polycystic ovaries on the ultrasound for a diagnosis.
That's absolutely right. And it is surprising and honestly a major source of confusion. That name is a bit misleading. You don't need all three features, just 2 out of the 3 usually. So yes, you can have PCOS without the typical ultrasound findings.
That's huge. It feels like that alone could explain some of the diagnostic delays people experience. All right, so let's pull back the curtain on the symptoms themselves. This is where it gets really interesting because, as you said, it manifests in so many ways. Some obvious, some less so. What are the key things our sources highlight?
Definitely. So one of the most common signs, often showing up early on, is menstrual dysfunction. We're talking irregular periods, maybe fewer than 9 a year, or sometimes no periods for 3 months straight or even longer. Often starts around puberty, maybe shortly after the first period.
Okay, that makes sense, the irregular cycles.
Then there's the hyperandrogenism. We mentioned those signs of high androgens. Hirsutism, that excess hair growth, is often a really prominent one for many women. But it's tricky because what counts as excessive can actually vary quite a bit depending on someone's ethnic background.
Right.
Clinicians use grading systems, but it's not always clear-cut. And besides the hair growth, you often see persistent acne, especially adult acne, and that male pattern hair thinning.
Got it. And the ovaries themselves, you mentioned the ultrasound finding?
Yes, the ovarian appearance. So if they do an ultrasound, they might see what looks like polycystic ovaries, technically more than 12 small follicles, usually 2 9 millimeters or just larger ovaries overall. But again, and this is critical for you listening, seeing that on an ultrasound isn't always there, and it's not strictly required for diagnosis using the main criteria. A normal ultrasound doesn't mean you don't have PCOS.
That really needs underlining, doesn't it? Because it's so counterintuitive given the name. So it's clearly not just about periods and maybe some visible signs like acne or hair growth. What else is going on? What are the sort of deeper impacts?
Exactly. This is where we get into the crucial metabolic and psychosocial impacts. This really shows its systemic nature. There's a very strong link to insulin resistance. This affects a huge percentage, maybe 40 to 85% of women with PCOS. And importantly, even women who aren't overweight.
Wow, that high.
Yeah. Insulin resistance means your body cells don't respond well to insulin, so your blood sugar can get higher. This ramps up the risk for things like type 2 diabetes, diabetes during pregnancy, gestational diabetes, and also dyslipidemia, which is abnormal cholesterol levels, and even non-alcoholic fatty liver disease.
Okay, so major metabolic connections there.
Definitely. And while not everyone with PCOS is overweight, obesity is common, and it can, unfortunately, make the symptoms and these metabolic risks worse. It's kind of cycle sometimes, but it's not just physical. The psychosocial effects are really significant too. We see a much higher risk of mood disorders, depression, anxiety. It can really impact quality of life. And there's also a link to eating disorders, particularly binge eating disorder. It's a lot to deal with.
That's incredibly important to highlight the mental health aspect.
Yeah.
So beyond these things, what about long term? Are there other risks, maybe further down the line, that our sources mentioned?
Yes. Looking longer term, sleep apnea is more common in women with PCOS. And tying back to those metabolic issues, there's an increased risk of cardiovascular disease over time. So, yeah, it has really broad implications for health across the lifespan, far beyond just periods or fertility.
It's so clear this isn't a simple checklist condition, which leads me to ask, what's actually driving all this complexity? If it's not one single thing, what are the underlying process and why the delays?
Yeah, you've really hit on the core challenge there. The most common diagnostic guidelines used worldwide are the Rotterdam criteria. Basically, you need 2 out of those 3 main features we talked about. 1, irregular periods or ovulation. 2, signs of high androgens, either clinical signs like hirsutism or high levels on a blood test. And 3, polycystic ovaries on ultrasound. And this is key, you also have to rule out other conditions that could cause similar symptoms.
Ah, okay. So it's also a diagnosis of exclusion in a way.
Exactly. That's where a lot of the complexity comes in. Doctors need to make sure it's not something else, like thyroid problems or high levels of a hormone called prolactin, or, less commonly, other conditions that cause androgen excess, like congenital adrenal hyperplasia, or very rarely, tumors that secrete androgens. So ruling those out is a critical first step.
So what kinds of tests are usually involved in that process? What are they actually looking for?
Typically, it involves blood tests. They'll check androgen levels, things like total testosterone, free testosterone, maybe DHEAS, which comes from the adrenal glands. They'll also check other hormones to rule out those mimics like TSH for thyroid function and prolactin. And sometimes, yes, a transvaginal ultrasound to look at the ovaries, but like we said, that's not always definitive or even necessary depending on the other findings.
And the delays you mentioned.
Yeah, the challenge of delayed diagnosis is very real. We see in studies that many women wait years, often bouncing between different doctors, before they finally get the PCOS diagnosis. It's frustrating, and it delays getting the right support and management.
It really paints a picture of how complex this is, not just the condition itself, but navigating the healthcare system to get answers. So, given all that complexity, what did our sources say about the deeper roots? What are the underlying influences? Is it mostly genetics, or is it more about environment, lifestyle?
Well, it really seems to be a combination. There's a strong genetic component. PCOS definitely runs in families. If your mother or sister has it, your risk is higher. But it's not simple genetics, like one single gene causing it. It's what we call a complex genetic trait. Multiple genes are likely involved, interacting with each other. The heritability, meaning how much is down to genes, is estimated to be pretty high, maybe around 70%.
70%, that's quite significant.
It is. But genetics isn't the whole story. It's about how those genes interact with environmental factors, things like your diet, your weight, maybe even factors during development like stress levels. These environmental or acquired factors can really influence whether PCOS develops and how severe the symptoms are. It's kind of like genetics might load the gun, but the environment can sometimes pull the trigger.
That's a really helpful way to think about it. And I think I saw something in the sources about ethnic differences, too. Does that fit into this picture?
Yes, absolutely. There's definitely ethnic variability. Both the overall prevalence of PCOS and how the symptoms show up can differ between ethnic groups. For example, the severity of hirsutism might be different in, say, women of South Asian descent compared to women of European descent, even if their hormone levels are similar. It just adds another layer of complexity and reinforces that PCOS isn't a monolithic condition. It's very individual.
Okay, so let's shift gears a bit. Someone has gone through that often long diagnostic process. They have a PCOS diagnosis. What comes next? How is it managed? You've stressed how individual it is, so I imagine the approach has to be really personalized.
Absolutely personalized. That's the key word. The management goals really depend on the person's main concerns and their life stage. But generally, the aims are to regulate menstrual cycles, manage those symptoms of androgen excess like hirsutism or acne, reduce those long-term metabolic risks we talked about, and, if it's relevant for them, support their fertility goals. And the absolute foundation, the first thing doctors usually recommend, is lifestyle changes. Primarily focusing on diet and exercise, often aiming for weight loss if the person is overweight. Even losing just 5 or 10% of body weight can make a huge difference. It can help periods become more regular, improve how the body uses insulin, and lower androgen levels. It's really powerful.
Okay, lifestyle first. But what about beyond that? If someone isn't trying to get pregnant right now, what are the common medical approaches for managing periods and those androgen symptoms?
Right. For women not currently seeking pregnancy, combined oral contraceptives, birth control pills are very often the first-line medical treatment. They do a few things. They regulate the menstrual cycle, they lower androgen levels, which helps with the acne and hirsutism, and they also protect the lining of the uterus from building up too much, which can be a risk if you're not having regular periods.
Okay.
Of course, like any medication, there are things to consider. COCs have a slightly increased risk of blood clots, venous thromboembolism, so that's always part of the discussion with the doctor. And if the pill alone isn't quite enough for the hirsutism or acne, sometimes anti-androgen medications are added. Spironolactone is a common one. It directly blocks the effects of androgens. And then, of course, for hirsutism, there are cosmetic approaches to shaving, waxing, electrolysis, laser hair removal, which can make a big difference to quality of life.
Makes sense. And what about tackling that metabolic side? The insulin resistance, the diabetes risk, cholesterol?
Yes, that's crucial for long-term health. Metformin is a very commonly used medication here. It primarily works by improving insulin sensitivity. This helps manage blood sugar, reduces the risk of developing type 2 diabetes, can sometimes aid in weight management, and for some women, it might even help regulate their periods a bit.
Interesting.
If cholesterol levels are high, dyslipidemia, then statins might be prescribed. And managing related conditions is important too, like using CPAP for sleep apnea if needed, or addressing fatty liver disease through lifestyle and sometimes medication.
Okay, that covers management when pregnancy isn't the immediate goal. But what about when it is? Fertility is often a major concern for women with PCOS. How does the approach change then?
Yes, fertility is a big focus for many. The approach shifts towards helping ovulation happen. And again, weight loss, if needed, is still the first step, as it can dramatically improve the chances of ovulating naturally. If that's not enough, then ovulation induction medications are used. The first-line options are usually oral medications like letrozole or clomiphene citrate. They work by stimulating the ovaries to release an egg. Metformin might sometimes be used alongside these.
And if those oral meds don't work?
Then there are more advanced options. Gonadotropin therapy, which involves hormone injections to stimulate the ovaries. This needs more careful monitoring. And in vitro fertilization, IVF, is another possibility. There's also a surgical procedure called laparoscopic ovarian drilling. It's less common now, but it's a minimally invasive surgery where they make tiny punctures in the ovaries. This can sometimes help restore ovulation and improve hormone balance.
Wow, quite a range of options there. And throughout all of this, it sounds like keeping an eye on mental well-being is critical too.
Absolutely essential. We can't separate the physical from the mental and emotional. Given that increased risk of depression, anxiety, and eating disorders, screening for these is vital. And making sure people get connected with mental health professionals for psychosocial support is a really key part of comprehensive PCOS care. It truly requires a holistic view. So you can probably tell by now, PCOS is, well, it's complex, it's multifaceted. It touches on reproductive health, yes, but also deeply on metabolic health, psychological well-being. But hopefully understanding all these different aspects and knowing the range of management strategies out there really empowers you, the listener, to advocate for the kind of comprehensive, personalized care you need.
Absolutely. It really underscores the need for better awareness, which makes me think, considering those diagnostic delays we talked about and just how wide-ranging the symptoms are, what if we had greater public understanding of PCOS? How might that not just help individuals get diagnosed faster, but maybe even shift how we think about women's health overall, something to ponder? What really stood out to you from this deep dive, and what questions does it spark for your own exploration? Thank you for joining us on the deep dive today.